I was actually tasked today to talk about how we put together complex opportunities, which I call them now, where people have melanoma that's gone to other places, and how we combine as a team treatment. So just to boil down that all those beautiful pictures, this is really all that Jim does. So we talk about melanoma and surgery. Historically, we remove the spot. We check, has the spot gone any place else? But we really never had great opportunities in the past to talk about surgery in the context of when the melanoma leaves its primary location and when it goes to other sites. Melanoma, as Sarah pointed out, it goes to the lungs, it can go to the liver, the brain, it can go to other areas on your skin and your lymph nodes, it can go to the bowel. And these are common things that we see a lot of now. Now, before we had any treatment that was very effective, and this was even 10 years ago, we really didn't do a great job of using a combined approach because we really didn't have anything else to add to the surgery. So, but there were still some patients that when we looked at them, we'd say, well, if this is only at one area, if we remove that area, they did pretty good. So people would live for a couple of years. And depending on where it was, people would also do well. But when you look over here, right, these numbers, thankfully, are very different now. And that's a lot of the hard work of the people who are sitting right in front of me at the podium, who helped to lead some of these first trials. Now, people who did well, though, when the only thing that we had in our toolbox was surgery, were people who, with Dr. Weisha, just people who had some spots on their skin that you can go in and take that out if it's locally in the scar. It's easily removable. Sometimes people would have one or two sites where it just go to a lymph node, and that's something that myself or Dr. Clune, we can easily take and remove. But when things were going inside of the belly, to the lung, the brain, these are really much more challenging situations. So major advancements, right? Nobel Prize winning work that was honored this year was looking at something called immunotherapy. So how do we utilize the tools that we already have to overcome cancer tricking our own bodies? So the advancements were with two drugs that came out. One is called ipilimumab, and the other one nivolumab, and there's other versions of these that many of you in the audience may have heard. This was really a game changer because all of a sudden, we're really good at taking out spots, but now we actually have therapies that can treat the spots that we can't see. The second one was one with a targeted therapy. So about half of melanomas will have a mutation in something called BRAF. And there's another medicine that many of you may have been on that actually targets two areas in the pathway. They're known as dabrafenib and trametinib, and Sarah showed that slide quickly, and Dr. Kluger will talk a little bit more about that. But it also gives us an opportunity because we can now treat spots that we can't see. We can do things to the spots that we can see too. So historically, so we had these things and we said, well, what do we do with surgery? So the first thing that we did is we said, okay, well, let's take out everything we can see and let's see how people do when we give them these treatments, and said, do people do better? And the answer is yes. So with certain agents like ipilimumab, people lived longer after you had a surgery and then you got treated. The same thing with some of the other immune therapies like the nivolumab or the pembrolizumab, and also the same thing for these mutation-specific targeted agents as well. People did live longer, so we took out everything that we could see. We gave you treatment, which means that, well, there was things that we couldn't see because some people benefited from that. Now, what we're seeing more is these newer scenarios that are coming in that we see probably on a weekly basis here at Yale. And those are when people come to us and they have melanoma that we can actually feel in their lymph nodes. Now, again, historically, the only thing that we could do is say, okay, we'll take out this spot and we're gonna take out all of these spots in your lymph nodes if they're in the armpit or in your groin areas. Or if someone had melanoma that had already spread someplace in the skin, nodes, anywhere all over the body that we actually couldn't remove with an operation. Before we didn't have anything else, but now again we have some therapies that we can use to try and shrink things down. And again, it's really been a good change when it's spread to different organs and different sites. And again, there's a lot of variability with it, but we have some opportunities. which gives us all a lot of hope. So again, this was where we started off. This was kind of the standard. So let's say that you had a big Goomba hanging out in your groin area, for example, right? I can take out that one spot, but it's just these little tiny little spots that we may not be able to see on our CAT scans that we're looking for an agent. So all of the stuff that you get treated with by the medical oncologist, right? It goes through your bloodstream, right? So it can go everywhere. I'm limited by the spots that I can see and the things that I can cut out, right? So that's why you want to combine these things together as much as you can. So again, this is where we started. So you'd see a spot. We would say, this is a risky spot. So we're concerned that you may have spots that we can't see. We'd remove that. And then we would give you either the targeted agents or the immune therapy. But in this case, let's say if you came into our clinic now and we said, well, there's a spot that I can feel, and we're starting to question everything, which is what we're supposed to be doing. So the question is if we give you the therapy while you have an area, a tumor in place, will you do better? We don't know. We're just starting to scratch that surface. And I'm going to show you some very early information on that concept. So what would be the benefit? Well, if you got a big spot someplace and we treat therapy, we can literally see with our eyes if something shrinks or not. The other thing is that, let's say you had an area where it was borderline that we thought we could take it out, but it would be a much, much bigger operation per se. All of a sudden you make it smaller. Sometimes that's easier for us. The other thing, and this is where, again, where we tie into what we do with all of the research that we do, is there's a question of sometimes if we have a tumor in place, that our immune system may have a greater opportunity to have more T cells that can recognize it and have a greater variety. And sometimes some of those T cells, depending on the environment, and again, it's like making a cake. You know, my grandmother used to do it without a recipe, right? Each one of your melanomas is unique. Each time she make Irish soda bread, usually came out okay, but it was always going to be a different variety every time she did it. So we're all unique, but we're trying to find out what makes your tumor different than yours, okay? So, and again, then that leads us to a chance to study, why are you unique? Why are you responding? Why aren't you responding? Because we can look at this in place and then we can remove it later and see what actually changed. How did your immune system react to that? So there's been two really early studies. These things have just been published within the last year and a half, where there have been some researchers who said, first, after we remove a tumor, compared to while the tumor is in place, the same treatment. So they got two different types of immune therapies. And they said, and this is the medical language that I'll translate. So if you got treatment before and after surgery versus just after surgery, when we look at x-rays, so people, obviously, if you didn't get anything, these boxes have to be blank, but about half of people actually had something we could see on x-rays or CAT scans actually shrink. And then importantly, if you got the treatment and then we removed it, when you looked under the microscope, 60% of people, so 6 out of 10 people, not a lot of people, okay, but enough that we should be scratching our heads and, you know, we get excited at night when we after we meet all of you during the day, is we said, you know, there's a couple of cells left behind, or almost all of them are gone. But as many of you in the audience know, you know, it comes at a price. So these agents, when we use them, we always have to have that balance of the yin and the yang of how they treat the tumor versus how they treat you. And again, these are very early studies, but many of these patients are still alive, and it looks like there's a hint that the patients who get it earlier actually do better. Again, very early. Second study, again, with a similar concept, was saying, well, we'll give you the 2 types of treatment versus 1 type of treatment. And the nivolumab or pembrolizumab, other people that you may know those names, you know, it has a little bit less side effects. So they asked the same question, said, okay, you have a tumor in place that I could remove with an operation. In this case, they also included areas that were far away, not a lymph node. It could be in the lung, it could be a spot in the liver, it could be a spot in the small bowel. And they asked the question, again, when we leave that in place and we give you treatment, how do people do? So again, looking at x-rays and CAT scans, about 3/4 of people who got the very strong immune therapy, they had things, again, that we could see on CAT scans shrinking. when they got the nivolumab, which is one of the single agents, only about 1 out of 4 people did they see. Again, remember, this is exploratory, small numbers of people. When they, again, looked under the microscope, almost half of those people had everything gone, that no one could see anything, in a quarter with people treated with the nivolumab. Again, the toxicity was the same, high when we use both of these agents, much lower with the single one. And again, maybe about 20% of people having a longer time before the melanoma has come back. So again, surgery plays an important role in select patients. There's also another scenario that, again, because we have effective treatments, you guys challenge us. We say, well, someone comes in and they've got a couple of different spots of melanoma, and let's say one of those spots grows and the other spots shrink, or some scenarios where we're actually able to remove all of them. We asked a question here at Yale, looking at all of you that we've taken care of, and said, how do people do? So if I'm able to take out all of the spots versus spots that have really shrunk and that your immune system may be keeping at bay, and only one spot maybe grow a little bit more, how are patients and people doing? And we were actually surprised when we saw that patients were doing quite well. So even if we removed a majority of the tumor that was present, and there were maybe a couple of little spots that were left behind, people were still doing well. So none of this is home runs, but from people who have lived this, from someone, I had one of my my favorite uncles pass away before any of these drugs were approved. We have a fighting chance, I think, and Dr. Kluger is going to speak a lot more to that. And so just in conclusion, this is actually, I'm thinking, to be my Halloween costume. I think only Dr. Leventhal would laugh at me if I walked in the office dressed up like a suspicious mole. Maybe we could start a parade or something at Halloween. But again, this is something that continues to evolve. This is something that we don't know all of the answers to, and something that actually, Dr. Kloon's talked about how, many of you educate each other in the communities. And again, it's you who are the people who are actually going to be educating us, because so many of you share your time, you share the specimens that were alluded to earlier before we began any of the talks today, and you are what actually makes all of these changes possible. So thank you.